This is QD Clinic, brought to you by RoomNow.live. Yes, we're back for 2020. QD Clinic is a daily video devoted to patient care and patient vignettes. This case is about non-adherence and what to do about it. So last week, while at the county hospital and discussing a case with our rheumatology fellows, the issue came up of a patient who was roughly 35, had lupus, was taking hydroxychloroquine, or was she? Meaning she should have been on an effective dose, but she still had active skin disease. And this is a patient who had previously expressed concern about the safety of hydroxychloroquine and was it going to hurt her eyes and whatnot. So I think there are two issues at stake here. One is the issue of treatment decisions, and the second issue is that of the relationship between the patient and the rheumatologist. As far as what to do therapeutically, this patient has active disease. This patient needs more drug. Does she need more hydroxychloroquine? Does she need to take hydroxychloroquine? Or does she need another agent? Well, the first step here is actually easy. Do a hydroxychloroquine blood level. It'll tell you whether the patient's on the drug or not, or whether the patient needs a higher drug. Because if you up the dose in this particular patient who's thin, you'll be going from a almost therapeutic dose of below 5 milligrams per kilogram in a very thin young woman to going up to 400 milligrams a day, where she'll be over the 5.5 milligram threshold. She'll be over 6 something, and you worry about then toxicity. Michelle Petrie and colleagues have shown that doing hydroxychloroquine levels are very effective in telling whether the patient is taking the drug or not. Maybe not so effective in telling you about the efficacy of the drug or optimization or correlating that with clinical outcomes. But nonetheless, doing a hydroxychloroquine level, which is widely available, can be easily done as a measure of compliance. You know, when this comes up with other drugs and other situations, if you have the choice between a subcutaneous injection or an IV infusion of a TNF inhibitor, a CTLA4 inhibitor, a IL-6 inhibitor, and compliance is an issue, go for the IV. You'll know what they're taking. So the data on compliance is really shockingly bad. When it comes to primary care, a study from Consumer Report showed that when a primary care physician writes a new prescription for an antibiotic, only a third of patients would fill actually 1/3 of patients would not fill the prescription, even though they went to the primary care for their cold and a want of an antibiotic. So that's kind of messy. And how do you deal with that? It's just as bad in rheumatology, where the data on hydroxychloroquine compliance and adherence is really quite bad. Several different studies show that 50 to 58% of patients are adherent to hydroxychloroquine when they have a diagnosis of lupus. That means that 40 to 50% of patients are not taking the drug that you prescribe, or certainly not taking as much as you prescribe. So that's problematic. Does this happen in other disorders? Yes, it happens in psoriatic arthritis. It happens in rheumatoid arthritis, where the data on biologics is that somewhere between 30 and 35% of patients don't take the biologic that you prescribe for their problematic inflammatory disease. So the question is, what can you do about it, and what's the consequences of this? Well, the consequence is cost. The costs are large. It's the cost of the disease not being controlled, which is sort of silent and deadly. It's the cost of delay in therapy. And it's the cost of an eroded relationship between you and the patient. So how do you deal with this issue of non-adherence? I mean, there are many ways to look at this. I think that you have to realize it's a matter of trust. And trust is in short supply in this world. And when patients are sick, newly sick, going to you, a new doctor, and you're Mr. Scientific with all your big words, you're scaring them. And trust is hard. So you need to engender trust. I love this quote from Seth Godin that says, "Nobody believes what I tell them. Nobody believes what I show them. They often believe their friends, and they always believe the story they tell themselves." That means if you want them to believe in you, you got to be their friend. Or you have to be, somehow get inside the story that they're telling themselves in their head. How do you be their friend? Well, obviously, an attitude issue, a communication issue needs to be under sort of made a priority by you. And I know that you didn't go to medical school to become friendly and to talk down to the patient level, but that's what's necessary to be successful as a physician. I think you should think about our paradigm, which says is see them, diagnose them, bring them back in 2 or 3 months. That's 2 or 3 months of them not taking what you prescribe. Maybe you should bring back new patients with new important therapeutic starts in 2 weeks to find out if they're taking the medicine or not, to find out why they're not taking the medicine, and to work on the issue of trust between you and the patient. Be sure to check out Room Now Live. It's March 13th through the 15th in Fort Worth. Go to roomnow.live, check out the faculty. Great rheumatologists like you go to great meetings like this. Tune in for more QD videos this week.